Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So the first question we ask ourselves is the disease amenable to surgery? And there are a lot of different surgeries that are done for mesothelioma, which makes some of the studies done in surgery for mesothelioma difficult to interpret. So I thought I would try to decode some of this alphabet soup that we use to talk about the different surgeries. So the first is a partial pleurectomy. So this is when they go in and they scrape part of the lining of the lung. But they don't scrape all the way around. So that's a fairly uninvasive, not invasive surgery. There's a pleurectomy with decortication. That is trying to get more of the lining and then taking also any part of the lung that has invasion. So there is some lung resected in that surgery. There's an EPD, which is an extended pleurectomy and decortication, similar to the previous surgery, but they really try to go all the way around as far as they can along the lining of the lung. This is probably the most common surgery done these days. And then the extrapleural pneumonectomy is essentially where you take the lung and the lining and everything from that side of the thorax out. And that was the most common surgery done previously, but has a high complication rate. So who gets surgery in mesothelioma? First, the disease has to be amenable to that type of surgery. Also, the histology, the type needs to be epithelioid. And one thing that I think is important as we think about this really big surgery is that a surgery for mesothelioma is not curative, meaning even if you cut out as much as you can, it still tends to come back at some point. The extrapleural pneumonectomy, which I talked about, is the biggest surgery, has mortality rates somewhere between 3 and 18%. So there certainly is some risk to that surgery, which is partially why it's not done very frequently anymore. But it does seem to be fairly effective. The recurrence is often somewhere else besides in that area. And if you get rid of everything on that side of the thorax, then you have no barriers to delivering radiation. There's no toxicity to a lung that's not there. So it does lend itself to additional radiation there. The pleurectomy with decortication, which is the most common surgery, now has a more reasonable mortality rate, but the recurrence is often local as you're not taking the whole lung. Other procedures you may hear about, talc pleurodesis is when they insert talc into the space between the lung and the chest wall to try to seal off that compartment. This helps, especially if people are having difficulty with pleural fluid that's developing in that space.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelexis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.